We know that over the last 20 years for non-small cell lung cancer, that we have identified subpopulations within this cancer type that respond very significantly to targeted therapies. We see this for patients with EGFR mutations and ALK mutations, as well as BRAF and ROS1. We've also now started to see more directed therapies to a new population for patients who have RET fusion mutations. So RET fusions are similar to these other types of targeted treatments in that it is a new type of what we call oncogenic driver mutation non-small cell lung cancers. They're more common in patients with adenocarcinoma, histology, in younger patients, in patients who are never smokers or just light smokers. We also see this with more poorly differentiated histology, as well as occasionally we see signet ring histology on the pathology reports for this specific patient population. We know that these RET fusions, the biology of them are that it creates a protein that is overexpressed on the surface of cancer cells that is basically constitutively active. So it's constantly on and constantly sending signals into the cell to grow and develop. And we know that this ultimately is what leads to cancer growth for oncogenic driven cancers. We also know that targeting this specific protein with a tyrosine kinase inhibitor can shut off the signaling and ultimately to responses and significant duration of responses for patients with these targetable mutations. There are several RET fusion mutations that have been described in the literature, though the most common are KIF5B, something called KIF5B, another one is NCOA4, CCDC6, TRIM33. Although this, in my mind, is sort of an alphabet soup, the most important one I would say to know is that the KIF5B is the most common of anywhere between 70 and 90% of cases. Though what we have started to see as we see more of these drugs in development, that sometimes one fusion partner may respond better than another fusion partner. So it's important to know that there are multiple different types, but that certainly many of these fusion partners have seen significant responses. So as many people know, when they're treating patients with lung cancer, we used to really treat everybody in the same way. We gave them platinum doublet chemotherapy and they had similar survival. But over the course of the last 20 years, we have divided patients with non-small cell lung cancer into different subcategories. In particular, people with adenocarcinoma are found to have what we call oncogenic driver mutations. The first of these that was really recognized and developed were patients with EGFR mutations, but we've also seen this now for patients with ALK mutations, for ROS1 mutations, for BRAF mutations, and as we recognize all of these different genetic alterations and mutations, we are able to personalize therapy for each individual patient based on what their underlying genetics of their tumor are. And RET, although there have been some targeted treatments over the course of the last many years that have been tried, it is only recently that we've seen development of very specific RET inhibitors that are allowing us to potentially offer something new to this patient population.